that. Okay.
I can't see that the recording has started.
I have. There we go.
Here we go.
Yeah.
Here we go.
So this is my psychology assessment, February 2021. So my topic was early stage Alzheimer's disease. So Alzheimer's is one of the biggest medical mysteries. It's the most common form of dementia, affecting 85,000 people in the UK. It's subdivided into the early and late onset, with the latter affecting 1 in 14 of our ageing population. Yet we don't know what causes it. It's a progressive neuroinflammatory and neurodegenerative disease caused by damage to cells in the brain that allow us to move, think and feel, starting characteristically in the medial temporal lobe, as you can see on that diagram, which plays a central role in memory processing. So this presentation will focus on the early stages of Alzheimer's, and these symptoms include forgetting recently read material, trouble organising planning, forgetting where valuables have been placed, trouble managing money, forgetting recent events, names, details about own identity and dates, trouble with challenging and wandering or becoming lost in familiar places. So the exact etiological and pathophysiological mechanisms are still the object of intense scientific research. Since 1986, the cause of Alzheimer's was thought to be due to the misfolding of two small proteins in the brain, amyloid and tau, which have normal homeostatic functions. This misfolding results in the accumulation of large sticky amyloid plaques and tau tangles, which are characteristic of Alzheimer's. These misfolded proteins alter the function of microglial cells in the brain, causing neuroinflammation, thereby disrupting the mitochondria, leading to oxidative stress, which we know plays a significant role in the pathogenesis of Alzheimer's. Increased metal levels are also been implicated in this process. But what causes it in the first place? Or what causes the misfolding? In 2016, a new theory emerged about the oral microbe, P. gingivalis, known to cause gum disease. It was actually found in the brains of 96% of Alzheimer's patients. So perhaps this could be the cause. Oh, sorry, I know what's gone wrong. Interestingly, as a consequence, amyloid plaques form as a sticky antimicrobial defense against the bacteria. However, some research suggests amyloid and tau proteins are suspected prions. These are proteins that exist as a basic infectious agent with their own intelligence and act like a virus. This is fitting, such that Alzheimer's is often considered a sporadic disease, meaning it starts without a cause. So moving on to the risk factors and protective factors, the biggest risk factor and unavoidable one for Alzheimer's disease is aging. Genetics is also unavoidable. Emerging data suggests that the apolipoprotein gene is the main genetic risk factor. It causes accelerated age-dependent cognitive decline with worse memory performance through amyloid-dependent and amyloid-independent pathways. Age and genetics are unchangeable, but we do have the power to change the other risk factors. Improving our dental health, from what I talked about earlier, and the quality of our sleep can help. Sleep deprivation is actually associated with the buildup of amyloid plaques. Other risk factors, depression may increase the risk of getting Alzheimer's. However, it actually might also intensify a predisposition to depression. Diabetes as well, although the exact mechanism is also unclear, a vast body of evidence does exist which links the two and with amyloid-dependent pathways. It's suggested that cardiovascular risk factors influence the progression of Alzheimer's, and these are very common in the elderly. Interestingly, lowering of cholesterol levels appears to reduce the risk. Long-term use of antihistamines has also been linked to Alzheimer's as a result of blocking acetylcholine, leading to brain damage in the brain which blocks the parasympathetic nerve impulses, which are involved obviously with involuntary processes. So chronic psychosocial stress also plays an important role in Alzheimer's disease. In a rat model, researchers actually demonstrated that even mild chronic psychosocial stress can push towards Alzheimer's disease. So there's overwhelming evidence that our lifestyle choices affect our risk. Professor Anne-Marie from Alzheimer's UK suggests that 40% of dementia cases may actually be preventable, which is really fascinating that these protective factors can cause that much of a difference. So physical activity is known to improve physical functioning and mood. There's a cognitive reserve hypothesis, which suggests that individuals with greater cognitive ability can actually delay symptoms. Eating a healthy diet, cutting down on smoking, and drinking less alcohol are all preventative, as is a good night's sleep. There's actually a mind diet, which has been recommended from the Alzheimer's, which is predominantly a Mediterranean diet, which is the main thinking is that it has an antioxidant effect. So also another antioxidant effect is also with these calorific restriction boosts, which have also been shown to help. So the diagnostic criteria, it's been quite a challenge to diagnose a condition before extensive brain damage is the challenge is to diagnose a condition before extensive brain damage has occurred, so that treatment of lifestyle changes can be made. Current diagnosis is based on an initial assessment, which may start in hospital or with your GP. It involves a thorough case history, including cognitive, behavioural and psychological symptoms and the impacts that they will have on their daily life from the patient and from the patient, someone that the patient knows well. It's possible for the cognitive difficulties for them to surface up to 8 years before a person fulfills the clinical criteria for Alzheimer's disease. But if Alzheimer's is still suspected, a physical examination is carried out, which includes tests, urine and blood tests, to exclude reversible cognitive decline. If again it's still suspected after these tests, cognitive assessments are done, and if it is Alzheimer's that's suspected, a verbal memory test is also done to confirm diagnosis. There's currently unapproved tests, although there's genetic screening, which screens for deterministic genetic mutations, but this is really for the early onset, not early stage. So this is when it occurs in people at a young age, i.e. it's still over the age of 30 though. There's a more promising biomarker that's recently been developed. It's demonstrated nearly 100% accuracy in determining an Alzheimer's patient as early as 20 years before symptoms. This paper only came out last year, so it's very, very new, very new data. And it's actually, you can actually take it from a blood test rather than cerebrospinal fluid, which is where it was developed. So obviously there's diagnostic difficulties, and you know, what we really have to consider is what's the ethical consequence of detecting this disease at this asymptomatic stage. As osteopaths, we may see more patients in clinic with this diagnosis. But what does this mean for these patients? How does this awareness of their prognosis predispose anxiety and depression? And how does this affect their management? Nonetheless, obtaining a diagnosis in the preclinical stage of the disease enables the implementation of known protective factors for delaying the onset of dementia. Common early symptoms include short-term memory loss and difficulty learning new information, which can make it really hard to function independently. But these symptoms can also be easily disregarded as features of aging. The behavioural assessment provides a scale with these symptoms can help classify and rate a patient's behaviour, which can be assessed by a caregiver so that they can alter the patient's environment and change their interactions to promote more positive behaviours. And then at the bottom, there's just some common comorbidities that go alongside the diagnostic criteria. And this is often chronic pain, of prevalence of depression, anxiety, and the somatic comorbidities that are seen in the elderly. So moving on to treatment, there's currently no cure for Alzheimer's, but there's a lot of support available to help someone live with the condition. Therapeutics must take into account the characteristics of the person who is likely to be elderly with somatic comorbidities. So Alzheimer's is currently funding a 3-year implementation project following the Great Randomised Control Study to maintain independence in everyday activities with Alzheimer's and related dementias through cognitive rehabilitation tailored to each individual. It addresses psychosocial methods that addresses cognitive and behavioural therapies to attain realistic and relevant goals targeted in the home therapy sessions that are offered. These goals address all the symptoms mentioned earlier with promising results, and there's more information in the handout about this. So attending to the needs of the caregiver is obviously critical for the support of the patient, as is physical therapy, as we've mentioned earlier. There's actually a very interesting paper on cranial osteopathy improving the function of the blood-brain barrier, and this has been implicated in preventative treatment for Alzheimer's. So whether there is room to take this further with also delaying the progression may actually be of further interest. Medical intervention should be carefully monitored in relation to somatic comorbidities due to the frailty of the demented aged population, and possible adverse reactions and drug interactions need to be considered. Hence, if the comorbidities of depression and anxiety are there, the drug of choice for antidepressants is the double SRIs. As these have less adverse reactions. Cholinesterase inhibitors are used for reducing the cognitive decline. So obviously with our treatment, it's also really important for the patient to talk to either a psychiatrist, clinical psychologist, occupational therapist, GP or dementia advisor. So moving on to the impact of early stage Alzheimer's on non-specific lower back pain. As we know, the causes of non-specific lower back pain can be multifactorial with a complex etiology. In most cases, a specific source of pain cannot be identified, resulting in the classification of non-specific lower back pain. It's highly prevalent and challenging to manage clinically. For Alzheimer's patients, the physiological factors will take into account the demographic trend towards elderly people. Furthermore, demented patients are often more frail than older people, with higher frequencies of somatic and psychological comorbidities and be on more than 5 medications. In fact, a small percentage of people may also experience back pain as a side effect of medication. Withdrawal from social activities may increase a sedentary lifestyle, leading to poor posture, which could also contribute to back pain. And then further, also research suggests that central sensitization of chronic pain overlaps the pathology of Alzheimer's. So this may synergistically increase the neurodegeneration and cognitive decline as well. It raises many questions that Alzheimer's may increase sensitization to pain, or pain may manifest differently in dementia parents, or that the cognitive decline may reduce the ability of the patient to recall the pain. So that these are all things that we need to consider when we're taking the case history and doing the examination. So psychosocial factors are prognostic in the outcome of back pain. And affect the individual's perception of pain interwoven with the physiological factors. I've considered red, orange and yellow flags and also obviously with the red flags, we'd obviously want to make sure there's no suicidal thoughts. But depression falls in under the emotional factors and an orange flag, and it's been associated with early stage Alzheimer's. There's obviously with those emotional factors, the fear of increased pain, along with the fear of losing independence. These are all psychosocial factors that represent obstacles to recovery. The fear of movement can cause pain, the fear of movement causing the pain seems to actually increase the pain. And this can lead to avoidance behaviours of daily activities, which may lead to the chronicity. And we've already seen that the pathology of chronic pain and Alzheimer's overlap, which again could exacerbate one or both of those conditions. So there's many other psychological factors, from fear of losing independence, concerns regarding dependence on caregivers, attitudes and supports of caregivers. There really is a lot. The fear of concerns about the progressive nature of Alzheimer's can impact the individual's expectations, their beliefs and attributions about their own status to control their own resources, as suggested by the cognitive model. These critical factors are critical to understanding the perception and meaning that the patient attaches to his or her pain. But we can refer them back to hobbies and interests that they may have mentioned in their case history, to engage them in activities that are meaningful to them to improve their quality of life. There's other social factors falling into the psychological factors, which can be due to a lower socioeconomic status. Can they actually afford to come to see an osteopath? These are all things that may impact or may represent obstacles to their recovery. So moving on to their management.
Sorry, I'm going to have to stop you there. You've run over.
Okay.
So if you can stop your recording. Okay, so you should be able to find the recording once the meeting has finished. It says it's still recording at the moment on my screen. I'm not sure if you've managed to stop that. If you go into more actions on the team screen again and go into the recording section, you should see an option to stop the recording.
Okay.